So good afternoon, everybody. I just want to make sure that you are able to hear and see us. Wonderful. So welcome to our Lunch and Learn session. This is a rescheduled session with Dr. Jean Wong, and the topic is on safer surgeries, specifically preoperative smoking cessation and whether that's a teachable moment. So as a reminder, as we usually do, if you are interested in obtaining a letter of completion for this Lunch and Learn webinar, you have to have fulfilled the 3 requirements, of which you would have already done the first, and the second and the third will become available. Sorry, the second is please sign in using your first and your last name, and the last one is the post-learning assessment, which will become available at the end of this session. Now, joining me today is Dr. Jean Wong. Dr. Wong is an associate professor with the Department of Anesthesia at the University of Toronto and University Health Network. Jumping along, her research interests include preoperative smoking cessation and perioperative outcomes. Dr. Jean Wong does have the disclosure of an honorarium for rounds for the University of Toronto Urology Department. As a disclaimer, these materials, as well as the verbal presentations and any discussions, are really only set out as general principles and approaches to assessment and treatment, and they do not constitute clinical or other advice to a particular situation and do not replace the need for individualized clinical assessment and treatment plans by healthcare professionals. The TEACH curriculum and the slides are developed and compiled with funding from the Government of Ontario, specifically the Ministry of Health and Long-Term Care, and the content of our slides are primarily based on evidence-based guidelines from the following 3 sources. Without further ado, I'm going to hand it over to Dr. Wong, who will begin our session.
So good afternoon, and thank you for the introduction, Leah. So I'd like to start by thanking Peter Selby for inviting me to give this webinar. I just want to say at the start that this is my first webinar, and so Leah has promised to give me a hand with any problems that I may encounter. And so, so my objectives this afternoon are to first describe how smoking increases the risk for surgical complications and why, as an anesthesiologist, we're interested in this area, and also to discuss and help the participants understand why the perioperative period is a teachable moment to advise patients to stop smoking. So I'll discuss some of the perioperative interventions that have been published previously, and also what we're currently doing at our hospital with a computer-based education module for smoking cessation, and discuss our pilot study results. And lastly, I want to identify the benefits of quitting smoking before surgery. So the World Health Organization has identified that more than 5 million deaths a year are attributable to smoking and smoking-related morbidity. And so in Canada, the prevalence has been estimated to be 17% of adults that are smokers. And in Canada, smoking has been described as the most preventable cause of disease and death, so similar to other developed countries. And in Canada, smoking is responsible for 1 in 5 deaths. So why, as an anesthesiologist, are we interested in smoking and the effects of smoking on surgical outcomes? So this is an area that there's a lot of studies that have been published, but this is one of the largest studies which is in the literature. This was published in 2011 in anesthesiology. And so in this study, it was a retrospective study where they included over 600,000 patients. And the data was obtained from the American College of Surgeons National Surgical Quality Improvement Program. And the data was gathered over about 3 years' time. And so they identified that 26% of their patients were smokers, and what they did is they matched 82,000 current smokers and propensity matched those patients to non-smokers. And then what they looked at was the morbidity and mortality over 30 days after the surgery. And so what they found was that in patients who were smokers compared to patients who were never smokers, that there was an increased odds for any major morbidity, as well as also an increased odds for death within 30 days of their surgery. So you can see that actually the risk, the odds for any infectious morbidity such as septic shock, sepsis, or a surgical site infection were about 1.4 to 1.5 times higher in a smoker compared to a non-smoker. As well, the complications related to cardiac causes such as myocardial infarction, cardiac arrest, or coma were about almost 2 times higher in smokers compared to non-smokers. And then for respiratory complications, the risk of requiring a ventilator for more than 48 hours after surgery was about 1.6 times higher. They were also at about 2 times greater risk for needing unplanned intubation after surgery, as well as about 2 times greater risk for pneumonia after surgery. So I just want to briefly review some of the cardiovascular and physiological consequences of smoking. So nicotine, it does cause sympathetic stimulation in that it increases heart rate and blood pressure and contractility, and this leads to an increase in oxygen demand. As well, carbon monoxide that is generated decreases oxygen availability and oxygen delivery, which results in a decrease in oxygen supply. And as well, smoking increases, causes activation of coagulation pathways and promotion of thrombosis. And so what does this mean in the perioperative period? It means that these patients are at higher risk for suffering myocardial infarctions as well as cerebrovascular accidents. So all of us, of course, know that smoking increases the risk for lung cancer, but in the perioperative period, so what are we concerned about? So smoking, of course, for anesthesiologists, we're very concerned about the effects of smoking on clearance of mucociliary secretions. And so smokers do have a reduction in mucociliary clearance. As well, they have increased mucus production. And smoking has an adverse effect on the pro-inflammatory responses and altered immune response, as well as increasing airway hyperreactivity. And so this means that during the perioperative period, when patients come for surgery, they're at higher risk for major respiratory perioperative outcomes, including pneumonia, respiratory failure, and unplanned postoperative mechanical ventilation. So, so this next slide, I apologize in that it's a very busy slide, but it's a nice summary of the effects of smoking on wound healing, and this was published in a nice review in 2012. And so to summarize, so smoking results in an increase in oxidative stress and a reduction in vitamin C. And there's 3 main responses. So there's a physiological response in a reduction of blood flow, reduction of aerobic metabolism, a reduction in tissue oxygenation, and this increases the risk for necrosis. And then as well, there's an impairment of the inflammatory cellular response, and so that there's a reduction in neutrophil oxidative bacterial killing, as well as a reduction in macrophage oxidative bacterial killing. And so this results in an increased risk for wound infection in patients who are having surgery. As well, there is the effect on the proliferative response, in that patients who are smokers have an increase in connective tissue degradation. As well, they have a impairment in fibroblast function, which results as well in a reduction in collagen synthesis. This leads to delayed healing, and this is well documented in patients who are smokers who have had surgery, as well as a increase in risk for wound dehiscence in the late phases for a hernia, and as well for unhealed tissue. So prior to discussing the effects of smoking on orthopedic surgery, so I just want to review the effects of smoking on musculoskeletal system. And so smoking has been shown to decrease bone mineral density, and this as well. And so these patients are at increased risk for sustaining a fracture when they do fall, or a tendon injury. And so it's been shown that there is partial reversibility of these risks when patients have stopped smoking for a longer period of time than 8 weeks.
Do you have 2 questions?
Oh, sorry. Okay.
Sometimes it helps to reread the question.
Oh, okay. So there's a question here about from Kelly Cronin, who has asked, have there been any studies on the use of NRT and how that may affect cardiovascular risk perioperatively? And so there are several studies that have, there aren't a lot of studies in this area, but there are some studies that have used NRT and for smoking cessation perioperatively. And these studies are relatively small studies with one of them has just over 100 patients, the other one has just over 100 patients. But from the studies that have been published up to this point, and again, there aren't a lot, but it doesn't appear that there's a higher risk for cardiovascular complications perioperatively. And this is always a concern for surgeons, and it's important to keep in mind, though, that these studies were not cardiac patients, and these were in non-cardiac surgery. And so there's another question here from Claire. Is this for general surgery healing, and does it apply for plastic surgery as well? And actually, there's a lot of literature in the plastic surgery field which have shown that this does in fact apply to plastic surgical patients, and most plastic surgeons actually will refuse to do surgery in a patient who is a smoker who is having any, and actually I was going to get to this a little later in my presentation, but who are having any major reconstructive surgery such as breast surgery, reconstructive surgery, or any flaps, or any microvascular surgery. Okay, and so, sorry, so getting back to, so smoking and orthopedic and spine surgery. And so smoking has been shown to increase the risk for non-union and for delayed union of fractures, as well as increasing the risk for infection, for soft tissue and wound healing complications. And for spine surgery, it's been shown that, that smokers do have an increased risk for non-union of spinal fusion. So this is a study that was published by Moeller, and it appeared in 2002 in Lancet. And so what they did is, and this is actually a study where they used NRT 6 to 8 weeks prior to the planned elective hip and knee replacement surgery. And so they looked at the effect of their smoking cessation program on wound complications and any complications. And so you can see that for patients who quit smoking, who are in the purple, they had a much lower incidence of any complication, particularly wound complications, compared to those patients who were smokers. And actually, this study was actually just recently e-published just a few weeks ago, but I thought I'd include it in this presentation. So this is a systematic review which included 10 studies, and they looked at the effect of smoking on rotator cuff repair surgery. And what they found was that patients who were smokers had poorer tendon repair quality, they had poorer biomechanics post-op, and in general they had poorer clinical outcomes. And in particular, they had impaired healing of small to medium rotator cuff tears. So, so plastic surgery, so again, it's been clearly shown, and actually in the plastic surgical literature, these studies are actually one of the there's probably the most literature in the plastic surgery area as well as in orthopedics, but it's been clearly shown that smokers have a higher failure rate for skin flaps, as well as for failed breast implants and failed microsurgery. And so usually plastic surgeons will actually not do surgery on a patient who has continued to smoke, although we do still get them coming through, but generally you know, these patients are told that they have to quit, or else, you know, they can't have their surgery. And so again, smokers having general surgery. I think there was a question here from Claire about general surgery. And so they are, and it's been shown that they are at higher risk for anastomotic leaks when they have bowel resection. As well, there are increased risk for wound infections, both superficial and deep. And there's a nice study from Sorensen which showed that smokers had a 4-fold higher risk of incisional hernia. So there's a question from Claire saying that the surgeons refuse to use NRT on their plastic surgery patients due to healing. And this is an area actually that hasn't been well studied. And so, sorry, when I referred earlier to the studies were primarily in non-cardiac patients. And actually, and the plastic surgical patients who are having microvascular surgery, those studies have also not, those patients have also not been included in the studies that have used NRT. And so at this point, it's not clear whether or not NRT may adversely affect healing of plastic surgical procedures. Does that answer your question, Claire? Okay, because it is something that comes up, and unfortunately there just aren't studies that have included plastic surgical patients and cardiac surgical patients. And so, it's been estimated that 5 to 10% of the population undergoes surgery annually, and in Ontario, it's been estimated that over 1 million patients have elective surgery. And so, extrapolating from a 17% prevalence of smoking, so there's a large number of smokers who are having surgery annually in Ontario, and so these smokers are at increased risk for postoperative complications. So there's another question here from Lori. So what are your thoughts regarding patients who use e-cigarettes prior to and after surgery? And so this is actually, there aren't any studies that have been published about the use of e-cigarettes around the time of surgery. There is a study which is ongoing that is being conducted in California, and I don't know when that study will be completed, but they are looking at e-cigarettes as a smoking cessation aid in surgical patients. But I think probably sometime next year we might have some early results from that study. So, so all of us are, and again, I usually give this, I usually speak to anesthesiologists and surgeons, but I think this audience today is aware of course of this. And so the World Health Organization has stated that all healthcare personnel and clinicians should consistently deliver smoking cessation interventions to their patients. And so, so just to review, what's the role of the healthcare providers? So again, I think this audience again is a little different from my usual audience, but smokers, it's been shown that they do want to quit. However, the success without help is only about 4 to 7%, and that patients do cite advice from a healthcare professional as a key to motivating a quit attempt. And it's important to remember that small successes in smoking cessation are clinically significant because of the large gain in health. So there's a question from Lauren here. I've heard of a client recently who was scheduled for gastric bypass surgery, and she was required to be tested for tobacco use to prove she had quit before the surgery and would be done. Has anyone else heard of this or known about this testing as a requirement before surgery? And so, and actually at our hospital we do gastric bypass surgery, and patients are requested to quit smoking before the surgery. And this is, again, because of the adverse effects of smoking on the healing of the anastomosis after the surgery. And often these patients do get some minor gastric ulcers, and so it's really important for these patients to stop smoking. We don't actually currently do actually testing, but we do ask them to quit smoking. So there's a comment here from William. From a dental perspective, post-extraction patients are advised not to smoke or drink from a straw because of the negative pressure generated can dislodge the clot and lead to exposure and inflammation of the alveolar bone and risk of a very painful osteitis. Dry socket. Okay. So just moving along. So to review what a teachable moment is, so it's a naturally occurring event thought to motivate individuals to spontaneously adopt risk-reducing behaviors. And some examples are a recent diagnosis of a stroke or cancer, coronary artery disease, diabetes, or lung disease. And so these have been shown to increase the likelihood that a patient will quit smoking by about 3 times. So it's been previously shown that undergoing major surgery does improve quit rates, and that major surgery was shown to double the likelihood of quitting. This was a study done in the United States, and not surprisingly, the highest quit rates were for surgery that was directly related to smoking-induced illness, such as having coronary artery bypass or having lung cancer. So does upcoming surgery have the same effect to improve quit rates? And so whenever a patient comes for surgery, either inpatient or outpatient surgery, they are required to be abstinent while they're in hospital. And so they also have contact with multiple physicians, including their family physician prior to their surgery, their surgeon and the anesthesiologist, as well as multiple healthcare providers, including the nurses, pharmacists, respiratory therapists, and sometimes physiotherapists, depending on the type of surgery. And as well, from having done studies in this population for the last few years, we find that what really, I think, crystallizes the teachable moment during the perioperative period is that patients have an increased perception of personal risk for surgical complications, and they expect to have a good surgical outcome. And so we find that they're really motivated to quit, as opposed to, especially if they're a younger patient, if, like a vague concern about lung cancer, 30 years from now. So it's a real, we find that for this reason, it's a real teachable moment. So the 5 A's of abstinence, so I think, again, all of you are familiar with this. And so in the perioperative period, is this actually practical, and can we apply it? And so the regulatory bodies in the United States and Canada actually have suggested that we anesthesiologists use a modified approach to the 5 A's, and instead to use an ask, advise, and refer approach, and that this should take 3 minutes or less. And so that every patient should be asked about whether or not they use tobacco. Every patient should be advised strongly to quit, and then that they should be referred to either a tobacco quit line or some other resource, such as their family physician. So how are we doing? So this is a survey that was done in the United States, but I think the results would be very similar in Canada. And so you can see that, so in the orange, so anesthesiologists are in the orange, and sorry.
Okay.
Okay. Oh, doesn't seem to be dragging. Oh, there. Okay. So you can see that the anesthesiologists are in orange and the surgeons are in yellow. And so you can see that most anesthesiologists and surgeons do ask all patients whether or not they smoke. However, when it comes to advising patients to quit, you can see that the surgeons do much better than anesthesiologists do. However, when it comes to assisting patients to quit smoking, neither anesthesiologists or surgeons do very well for assisting patients to quit smoking. So what are some of the barriers to providing smoking cessation interventions preoperatively? So one of the widely cited factors is a lack of time. And so in the pre-admission period, and especially in the pre-admission clinic, so the patients have to have blood work, ECGs, they have to see the nurse, they have to get their preoperative teaching and see the anesthesiologist. And so most pre-admission clinics are very busy. There may be a lack of knowledge. There may be a lack of training. There may be a lack of familiarity with treatment options that are available. There may be a lack of funding, and there also may be a lack of ability to provide follow-up. So there's a question here from Catherine about she's doing a study on smoking cessation in hip or knee surgery patients, and I'm realizing it's difficult to find time for that teachable moment when patients have so many individuals to see prior to the research team. And any thoughts on making this work efficiently and effectively? And so this, of course, is always a challenge for anyone who does work in a preoperative clinic. And so we've been conducting studies for the last 5 years in our preoperative clinic on smoking cessation. And so what we find is that we do try to see the patients whenever, and sometimes they can be waiting, up to 2 to 3 hours before their pre-admission clinic visit is completed. And so what we try to do is we try to coordinate things between the nurse, the pharmacist, the anesthesiologist, so that everyone is aware that the patient is eligible for the study. And so we try to communicate with all of the staff by actually placing a letter in the front of the chart to make sure that everyone is aware that the patient is eligible for the study, and so that we sort of grab them whenever we can in between while they're waiting to see the next person. And we find that actually it's challenging, but it works quite well for us. I hope that answers your question. And so, getting back to preoperative smoking cessation and respiratory complications, and some of the barriers being a lack of knowledge of smoking cessation interventions and the effect on perioperative complications. And so, this study actually appeared back in 1989, and actually it's quoted widely in anesthesiology as well as surgical textbooks. And so in this study, what they looked at was the respiratory complications in patients who smoked and those who quit greater than 8 weeks before surgery versus those who quit smoking less than 8 weeks before surgery. And so what they reported in their study is that patients who quit smoking less than 8 weeks before surgery had higher risk for respiratory complications. And so and those who quit smoking greater than 8 weeks before surgery actually had a decreased risk for respiratory complications. And so this led to anesthesiologists and surgeons feeling that it was not, it would actually increase risk for respiratory complications if patients were to stop smoking less than 8 weeks before surgery, and that they should just allow patients to continue smoking. However, when this study was when you actually read through it and actually when you calculate the p-value, it's actually not significant. But for some reason, this study was, it's quoted in all the anesthesiology and surgical most of the textbooks, and so this is something which is still, when I do present, many people still believe this study, but it's actually the only study that has ever shown this, and it actually wasn't statistically significant. And so I think this is also one of the barriers to anesthesiologists advising patients to quit smoking prior to surgery, because we usually see them within 3 weeks before surgery, and so we don't usually have that lead time of 8 weeks prior to their surgery to advise them to quit. So this is a meta-analysis that we published a few years ago, and what we looked at was the effect of quitting smoking between 2 weeks before surgery, between 2 to 4 weeks before surgery, more than 4 weeks before surgery, and more than 8 weeks before surgery compared to those who continued smoking. So actually we found that there was no increase in risk for respiratory complications in patients who quit smoking less than 2 weeks or between 2 to 4 weeks before surgery compared to patients who continued to smoke. However, you can see that there's a benefit in patients who quit smoking more than 4 weeks before surgery. So they did have a lower risk for respiratory complications, and that risk was reduced even further when they quit, not surprisingly, more than 8 weeks before surgery. So is there any benefit? Again, often anesthesiologists and sometimes surgeons too, we see patients only like a week or two before surgery. And so is there any benefit to asking them to quit when it's so close to their time of surgery? And so, so it's important to remember that nicotine has a very short half-life of about 1 to 2 hours. And so when patients stop smoking, actually there's a reduction in their heart rate and blood pressure within 24 hours. And carbon monoxide also has a very short half-life, and actually the carbon monoxide levels return to near normal levels within about 12 hours. And this study that was published in 1999 showed that for patients who smoked on the morning of the surgery, they had more episodes of SD depression than patients who were non-smokers, past smokers, or chronic smokers who didn't smoke before surgery. And so certainly it seems to be beneficial to still quit smoking even a day before surgery. And so I've already discussed the increased risk for wound complications, but again, this slide demonstrates in this meta-analysis that patients who quit smoking more than 3 to 4 weeks before surgery were at lower risk compared to patients who continued to smoke at the time of surgery for wound complications. So what about if you see smokers on the day of surgery, and is it still worthwhile to ask them to quit smoking? And so this is a study that was done in orthopedic patients, and so these patients had fractures of their upper or lower limbs. And this is a randomized controlled trial where they participated in a smoking cessation intervention for 6 weeks after their surgery, and they were followed until 12 weeks. And so in these patients, actually, the risk for complications were 2.5 times higher in those who were in the control group compared to the patients who were in the smoking cessation intervention groups. And so certainly, and wound infection was the most common complication in these patients. So Joanne has a comment or a question. If they quit just before surgery, will they end up coughing up more phlegm, which would cause problems? And so again, and that was what the rationale for the previous study from Mayo Clinic about the increased risk for respiratory complications in patients who quit smoking less than 8 weeks before surgery. And so there was actually another study that was published which showed that patients who quit smoking less than 4 weeks before surgery had an increase in phlegm, but actually it was a small study, and they actually just measured the amount of phlegm that was suctioned up at the end of the surgery, and actually there was no increased risk for respiratory complications. And so certainly, even though, and that's just one study that has looked at this, and so there isn't a lot of literature in the area, but certainly it doesn't seem like there's an increased risk for respiratory complications. I hope that answers your question. And so what about quitting smoking after surgery? Again, sometimes the patients aren't able to quit before surgery. And so this is a study that was a retrospective study published in patients who are having lumbar spine fusion. And so they found that the non-union rate was not affected so much by pre-op cessation, but actually that for patients who quit smoking after surgery for more than 6 months after surgery, that these patients had improved non-union rates compared to those who continued to smoke. And so for certainly for spinal fusion surgery, where the healing takes place over a longer period of time, it certainly seems that quitting smoking after surgery is really important. And so how much time do I have? 25 minutes. Okay, all right. And so we know that stopping smoking before surgery is beneficial, and so our preoperative smoking interventions effective to reduce postoperative complications. And so again, there aren't a lot of studies in the literature, but this is a systematic review of the literature that was available in 2009, and actually it does show that of the studies that are available, preoperative smoking interventions do reduce the risk for postoperative complications. And so what about the effect of preoperative smoking interventions on short-term abstinence? And so we published this systematic review, and we did find that there was an increase in short-term 3 to 6 month abstinence after surgery with the studies that have looked at preoperative smoking interventions. And so this is a study that we published in 2012 where we looked at this was a double-blind randomized controlled trial where we looked at varenicline versus placebo with perioperative counseling in both groups, and we included just under 300 patients at 2 sites. So what we found was, so the red indicates the varenicline group, and the blue is the placebo group. And so we found that abstinence was certainly improved in the varenicline group compared to the group receiving placebo, and we followed them for 12 months. And actually, even in the placebo group, the abstinence at 12 months was about 25%. Okay, sorry.
Mary Lynn, Jennifer, and
okay. So there's a question from Mary Lynn. It's, in the Ask, Advise, Refer model, is the referral process a formal referral completed by the healthcare provider for services, or are patients provided with contact information for tobacco cessation services or resources? And so actually this is an area that isn't, it's actually, currently there isn't sort of a standard protocol or procedure for this. And even though our regulatory bodies have advised us to do this, it's left to each hospital and each practice to decide on how to provide this. And so currently there isn't a standard for this. So Jennifer has a question: is there any research on using NRT pre and post-op and wound healing? And so most of the studies have used NRT for preoperative, for the preoperative period, and there are a few studies that have looked at it post-op. Again, there isn't, and these are all in non-cardiac patients and also in not including plastic surgical patients. So there's a question from Sandra about what do I mean by non-union, and so that would be non-union of the bones, and so in surgical, in spine surgery, that means that when they fuse the vertebrae, and then it doesn't fuse. So Sheila. Should I read this? Okay. Yeah. Okay. All right. Okay. All right. And so this is a study that was published last year from a group in London. And so this is a perioperative smoking cessation program and a randomized controlled trial that they conducted. And so what they did in their treatment arm is they provided brief counseling, brochures, and a referral to Smokers Helpline, as well as 6 weeks of NRT or no intervention. And they found that the 30-day postoperative smoking cessation rate was 28.6% compared to 11%. But currently, there isn't any standard or consistent practice when it comes to preoperative smoking cessation in Canada. However, the Canadian Orthopedic Foundation has recently started a Stop Smoking for Optimal Orthopedic Surgical Outcomes, and what their program involves is a referral to Smokers Helpline. There's a referral to a retail pharmacist. There is a letter sent to their family physician, and they're currently conducting a pilot study at 5 centers in Ontario. And so, I want to briefly discuss now a study that we're currently conducting. So we've developed a computer-assisted preoperative stop smoking cessation program, what it is it's a computer educational module, and we also provide brief counseling and/or pharmacotherapy. We refer the patients to Smokers Helpline. We also provide a letter to their family physician. So computer or web-based patient education, it's been shown that you can provide consistent and comprehensive information. It can simulate, it can be created to be interactive and simulate a face-to-face counseling session. It can be more widely reachable and cost-effective, and can potentially be accessed from a medical office or from a patient's home. It's been extensively studied in the general population. It's been shown to increase abstinence by 17%. However, it's not been extensively studied in the surgical patient population. And so a group in Australia is the only group that's really worked in this area, and they published a study back in 2002 where they created a computer-based patient education module. And they found that the quit rate at the time of surgery was about 60%, and at 9 months it was about 13%. And this was part of a multifaceted intervention. So in the module that we've created, so we provide some general information about smoking. We specifically discuss smoking and perioperative complications and explain how to quit and cope with quitting. We provide tailored information for the specific type of surgery that they're having, and there's also a pre- and post-module questionnaire that the patients complete. And so, we completed a pilot study of 30 patients, and actually we found that prior to completing the module that that most patients did know that it was important to quit smoking before surgery, but a lot of patients actually weren't aware that the risks associated with the risk of complications was higher in smokers. 50% of patients actually weren't aware that smoking increased the risk for surgical complications, as well as risk for anesthetic complications, and actually a surprising number weren't aware of how to cope with quitting or aware of the Smokers Helpline. And after completing the module, more patients were planning to quit before surgery. And so did these patients actually quit? And so at the time of surgery, 30% of patients had quit smoking. And of the patients who were continuing to smoke, about 16% actually had reduced the amount of cigarettes they were smoking. And the quit rate at 1 month was 26%. Oh, sure. Oh, Mona. Oh, sorry. So there's a question here from Mona. What is the education site? And so actually, we're currently conducting this study at the Toronto Western Hospital and Mount Sinai Hospital. And so once we complete the educational module, what we're hoping to do is actually put it on our UHN website so that it can be accessible for patients. And so so we expect that our study will be completed sometime next year, and then so probably in the following year we hopefully will have it on our website. So to conclude, so I hope you'd all agree that the preoperative period is a teachable moment for smoking cessation interventions, that a perioperative team approach should be used because again, and at our hospital, we've educated the nurses, the pharmacists, everyone in our preoperative clinic, and so the patients are getting advice from multiple health professionals, and that smoking should be treated like any other comorbidity. It's one of the few modifiable risk factors that can really make a difference in improving surgical outcomes, and it's also a public health intervention that we can offer. So. And so, so there's a question here from Marcy. Is it the nicotine that is the problem or the smoking? And should NRT be recommended as they prepare for surgery? And so actually there are studies in the animal literature and in experimental literature that suggest there's sort of a conflicting result in that some studies actually seem to suggest that nicotine on its own may actually improve wound healing, but it's actually actually that it's the combustion products from smoking, like the tars, the toxins, that are actually the cause for the impaired wound healing. But it's important to remember also, though, that nicotine, because of its sympathetic stimulation and effects on vasoconstriction, it will reduce the blood flow to the healing tissues. There's a question from Jennifer. There's a systematic review on wound healing published. Conclusion is that any adverse effects of NRT are minimal. And again, this is an area that hasn't been well studied, and again, most of the studies are small, but from the ones that are available, certainly in patients who are having non-cardiac and not having plastic surgery, it appears that there isn't an adverse effect.
I think we just need to scroll down.
Oh, okay.
Yep, just trying to go down. Perfect. I just jump back a little bit.
Oh.
We're at Maryland.
Oh, okay. So is the quit rate at 1 month post-surgery? And for the pilot study, that was for 1 month after surgery. And so from Claire, can you tell me your source for slide number 28?
We can do
I'll have to get back to you about that. Slide 48, is that 6% quit at 1 month? And yes, that was at 1 month after surgery. There's a question from Jewel. Can you provide information on the optimal time to quit for chemo, radiation, and surgery? I was only able to view the slides now, but you're providing the time to quit for surgery. And so I'm not aware of studies which have specifically looked at the ideal time to quit before chemo and radiation. However, all the studies that I'm aware of have just looked at surgery and not have included, and they haven't included chemotherapy and radiation. So certainly for surgery, for respiratory complications and wound complications, it's been shown that a period of 3 to 4 weeks is necessary to reduce the risk for those complications. Are there any other questions? Oh, sorry.
Can you comment on quitting for cancer patients?
Okay. So Jill has a question about can I comment on quitting for cancer patients? And so I can comment on having cancer patients having surgery. And so usually patients are actually, we find, quite motivated to quit when they have the diagnosis of cancer. And so we find in our clinics that patients who, again, similar to the study that was published from Mayo Clinic, that patients who are having surgery that is related to a smoking-related disease are much more motivated to quit smoking. Sharice has a question. Is there any information available about your pilot study? So we did publish our an abstract about our pilot study in October of last year in anesthesiology. So there's a comment here from Claire. The latest report from New Zealand does support decreased postoperative complications for those undergoing surgery post-chemo and radiation. Look up the newest release from New Zealand government. So thanks for that information, Claire.
Okay, well, thank you so much for that, Dr. Wong. It seems that most of our questions have been answered. So we do have a few minutes remaining, so if you'd like to remain on and type your question in the chat box, please feel free to do so. As a reminder, a link to this webinar evaluation will be sent by email. As well, you will also receive a link to the post-learning assessment, in which you will have 1 week to complete the post-learning assessment to receive your letter of completion. Please be sure to join us for our next webinar. Our next Lunch and Learn is scheduled for Wednesday, June 25th, in which Dr. Robert Reed will be joining us to discuss the topic of evaluating the effectiveness and outcomes, specifically the Ottawa model. And thank you everyone again for joining us both by the teleconference and by the Adobe Connect platform. We hope you have a wonderful remainder of the day, and we hope to see you at our next webinar.